Hi, my name is Sean Harnois. I am currently a P4 at Drake University in Des Moines, Iowa. Today I'll be talking to you about severe COPD exacerbations. One thing to keep in mind is that these opinions are my own, and it's my own personal research based on the sources cited at the end of the presentation, so do not let it affect your clinical decision making. Objectives of this will be to understand what a COPD exacerbation is, as well as some of what the causes are, go into the classifications, and then the goals of treatment for COPD exacerbations, and then maybe differentiating some of the treatment options themselves. Exacerbation of COPD is defined as an acute worsening of respiratory symptoms that results in additional therapy. Some of these respiratory symptoms can include cough, dyspnea, and sputum production. Some of the precipitating factors for COPD exacerbation, most common one is going to be respiratory viral infections, so like the common cold, the rhinovirus. And one thing to keep in mind is that exacerbations associated with viral infections last longer and are associated with increased hospitalizations when compared to bacterial infections. Some of the common pathogens for bacteria are H. flu, P. aeruginosa, and strep pneumo. And there's also some environmental factors that can affect COPD exacerbations, and those include air pollution and temperature, as well as some others. General COPD exacerbation classifications, mild, you would only want to use a short-acting bronchodilator. For moderate, you'd want to use a short-acting bronchodilator plus either an antibiotic or corticosteroid. And for severe, you'd want to use the same treatment as moderate, except what differentiates is that it requires hospitalization. And then for admission to an ICU, admission criteria includes severe shortness of breath unresponsive to initial treatment, possible changes in mental status, worsening in respiratory status, and a need for mechanical ventilation. Classifications for hospitalized patients. This is just some neat information. So as far as classifying it as life-threatening or non-life-threatening acute respiratory failure versus no respiratory failure, you want to compare things like respiratory rate, accessory muscle use, altered mental status, and hypoxemia improved with supplemental oxygen. So looking at those, you can kind of classify it a little more in depth. Management of exacerbations, mainly going to be bronchodilators, systemic corticosteroids, and antibiotics. So as far as bronchodilators are concerned, they're going to be the initial treatment for acute exacerbations, going to be used for, as shown earlier, kind of mild, moderate, and severe, kind of the cornerstone treatment. Short-acting beta antagonist with or without short-acting anticholinergics. And then there's, when you compare nebulizers to metered dose inhalers for the treatment, studies have shown that there's not really any significant difference between the two as far as outcomes are concerned. However, nebulizers may be a little easier to deliver for sicker patients. So that may be why you see those more on hospital formularies. And then one thing to keep in mind is that if a patient's on a home inhaled corticosteroid, some studies suggest holding that inhaled corticosteroid throughout their stay because steroid use has been suggested to increase risks for pneumonia. And when looking at systemic corticosteroids, purpose is to improve lung function, oxygenation, shorten recovery time, and hospitalization duration. Main medications are going to be prednisone or methylprednisolone. So prednisone is going to be your oral option. That's 40 milligrams a day for 5 days. And then keeping in mind, just like I said before, you want to use shorter duration because longer durations can be increased increased risks of pneumonia and mortality. Methylprednisolone is going to be your IV option, a lot of times used for more severe cases, and that's typically dosed as 1 to 2 milligrams per kilogram every 6 hours. A suitable alternative would also be nebulized budesonide, so you may see that here and there. Combination therapy for inhaled corticosteroid and LABAs for 10 days can possibly be associated with decreases in exacerbations. So those may be good options so when like a patient discharges, maybe sending them home on that medication may lower their risks of, having an exacerbation in the future. When looking at antibiotics, the purpose is going to be to reduce treatment failure and reduce mortality in those who are hospitalized or in the ICU. Empiric treatment is going to be with augmentin, 5 to 7 days, macrolides, 7 to 10 days, and tetracyclines. Tetracyclines are going to be used until symptoms have subsided for more than 24 or 48 hours. When looking at choice for antibiotics, the biggest factor is going to be the local antibiotic resistant rates. That's going to be the main factor you look at when deciding. If the patient has frequent exacerbations, severe airflow limitations, or exacerbations requiring mechanical ventilations, cultures could also be performed, as Pseudomonas has an increased likelihood of being the culprit. This is, so I, threw in all those abbreviations. This is kind of just a chart to kind of, what are the LAMAs, the LABAs, the ICS LABAs, the alphabet. So just helpful source for you to take a look at. These are my sources used. Thank you